Hello and welcome to the Healthcare Huddle video podcast. I'm Rachel Slawson and I'm the host of the show. And this is our fifth episode in the series where we talk about investigating transmission of Covid-19 within health and social care settings. In this episode, we'll be answering questions that we've received based on the other episodes. So if you haven't seen the other episodes, I will leave a link in the description to the playlist and I suggest you go back and watch those because then it'll all make a lot more sense. We will be talking with Lesley Underwood, registered nurse and public health professional. Lesley wrote the article entitled Investigating Transmission of Covid-19 Within Health and Social Care Settings. You can find a copy of this article on the Fascia Melius website, that is fascia-melius.org.uk. This is the fifth episode, as I've said before, in a series of 5, and these are aimed at health and social care professionals. Fascia Melius are sponsoring this series of podcasts, and they are a healthcare consultancy firm which offers a unique combination of insight, innovation, and experience. They specialise in quality, governance, and patient safety investigations. Hello, Lesley, how are you?
I'm fine, thank you, Rachel. Lovely to be here again. Nice to see you.
Yes, it's the 5th one. I can't believe it. It's flown by.
It has. It's gone very quickly.
Do you want to just give a little bit of a background about the article and a brief overview of what we've covered in the previous episodes? As I say, you should definitely go and check those out if you haven't watched them.
Yeah, just to talk about the article to start with. I've got a background in serious incident investigation, and listening to the press and what's going on out in the general world, people are sort of reflecting or starting to reflect on what's happened and how we've come this far. So I thought I'd put something together just to start people thinking in terms of COVID specific, so that people can actually start to reflect on how well they did to start with, and then moving forward, maybe where things didn't go quite so well. So really it's a discussion piece just to get people thinking. And in terms of the podcast we've done so far, we've just looked at various elements within an investigation and related it specifically to COVID-19.
Yeah, really, really helpful content. So the first question number 1, is it feels as though we are being blamed for the transmission of COVID-19. Do we have to undertake an investigation?
Okay, so as I said in my bit of the introduction, it isn't about blame. This is about understanding what happened. It's about being open and honest with ourselves as well as with our patients and service users to look at what we did well. And I think we did so much that was really superb practice, and getting that learning out there because there were others who were struggling. And if we have wave 2 or if we have issues when flu season arrives, then I think if people can learn from how others did well, then actually there's huge benefits to that. But also there were things that could have been done better. We know that. Some things were out of our control, and that's fine, but actually we need to plan for next time. So those things we know are out of our control, how are we going to manage them next time round? The whole aim of this is to stop harm happening. So therefore, yes, we do need to do it. It isn't necessarily pleasant, but certainly sing what went well from the rooftops because everybody needs to know. But I think those people who have suffered and those families who've suffered do deserve an answer as to what happened, how it happened, and what we're going to put in place to stop it happening again.
Yes, really, really important, particularly for people who have been affected adversely if something has happened in hospital. And I think it promotes the healing for them to move on from that. The open and honest dialogue, it builds trust back. Obviously it can't go back and undo the harm, but it can build trust going forward, and then people feel like they've had a voice and they've been listened to, and that's being taken into account, and then nobody else has to experience the same thing ever again, hopefully.
Yeah, and also with the staff, they need to know that they've been listened to and that their difficulties have been understood. It works both ways.
Yeah. And that process of learning, and sometimes the environment or the systems actually work against staff to be able to provide the best care that they can. And so actually those systems need to be sometimes undone, and new ways of thinking brought forward so that it empowers staff and staff can work in the optimal environment to help patients. So question number 2 is, how do we identify which COVID transmissions we should investigate?
Okay, well, as always, I would start with those cases where most harm has been caused. So where patients have died, where staff have been affected and unfortunately passed away. Now, trusts and organisations should already know those patients. For quite some time now, we've had reviews into patients who die within care, and those reviews will look at the circumstances surrounding that. Now, it might be an expected death, and COVID may come under an expected death in some organisations if somebody's been in intensive care for a long time, etc. But you would know which patients had died as a result of COVID. So therefore, I would start with those first. From there, I would look at those who've had extended stays in hospital, those who've had to go into intensive care where they wouldn't normally have had to do so, those who've gone into care from hospital where they wouldn't normally have done so. So they would have been expected to go home, for example. Those are the sorts of cases I would start to look at in the beginning. But along the way, I would be picking up the stories of the staff and their struggles, and also starting to gain the information about what they did well and how things worked well for them, so that you get the whole picture. So it's not just focused on what didn't go well. It needs to be a balance about what went well and what didn't go quite so well, and what can we change for the future. So I would do it in a systematic way in terms of most harm first, down to least harm.
Yeah, and that makes a lot of sense, and that's generally how they would work anyway, isn't it? How hospitals and investigations would work anyway. Is that correct?
Normally, you would have a serious incident investigation where serious harm has been caused. So, for example, if a death has occurred, but you may have an internal investigation if it is a case of somebody's had an extended stay, or you may not investigate if it was one transmission where not a lot happened. The patient caught it, but they recovered, they went home, there wasn't an issue. That said, you can also do investigations where there have been near misses. You can also do investigations where you have lots of low harm. So if transmission has occurred a lot of times, but actually the harm wasn't too great, so people recovered and went home, you can do an investigation looking at what went wrong or what went well during that time as well, just to see what happened, what changed, what was the differences, were there any common factors if COVID was being transmitted often within a team.
Yeah, that makes a lot of sense. If you were to undertake an investigation, who would you need on your team?
Okay, so I would expect there to be some experts involved. For example, an infection prevention and control expert. Now, if it's a hospital scenario where you maybe have 2 different sites, so 2 different teams, I'll possibly pull one in from the opposite site where the incident happened. They can give you the ins and outs of the infection prevention and control situation, what was going on at the time, and anything particular to infection control that was happening at that point in time. I would also like somebody from the area itself. So if this happened on a surgical ward or a medical ward, or in A&E, then I would like somebody from that speciality. And that's because there are different nuances in each area of expertise within health and social care. So you would need somebody there who understands the systems and the processes. There's also much to be gained from having somebody in an admin type role. Somebody who can get policies, can get procedures, can get notes, records, who knows people. Very often you'll have a situation where you need some information but don't know where to go and find it. So somebody who has that background knowledge is really, really helpful. But then as the investigation unfolds, you find you need information about other things. So for example, if there's issues over PPE, and the procurement of PPE, what you might want is to draft in a specialist from procurement to say, okay, what happened? What was going on at this point in time? Explain to us, explain the situation, explain what was going on, so that we can understand as part of the investigation. So that sort of is the basic team. Obviously, you need to be led by somebody who knows root cause analysis in whatever form they've been trained in, so they will take the lead. But ultimately, those are the sorts of people you would expect to have on an expert team.
Yeah, get all of the experts from all of the different disciplines and start having that discussion. As you say, you might not be able to provide a comprehensive list right now because it will be tailored to whatever environment that you're in at the time. But to think as wide as possible, and I like that, get more of the system involved, because you're more likely to be able to resolve it and really find out what's going on if you've got all of the right people in the room. Question 4, can I get support during an investigation?
Okay, well, there's 3 possible scenarios for that. If you're the team or the person being investigated, then yes, there's always support available. So firstly, your manager should be supporting you, and the senior managers should be supporting you. Your team should be supporting you. The team should support each other. So there's that sort of support available. There's also, within the organisation, there should be some sort of organisational support, either external or through occupational health. So again, people can go and seek support that way. There's the unions. If you're involved in the unions, then very often I've interviewed people with the union rep sat next to them. That's absolutely fine. As I said way back, we have nothing to hide. This isn't about being covert. This is about being open and honest and tell me what happened and how did it happen. But also you can get support from the investigators themselves. Investigators shouldn't go in and not be able to support those people they're interviewing. I feel very strongly that we should have the information about where those staff can get support. It's an emotional time for people, and actually to support them through it, to enable them to reflect on what happened, is a skill that you need to undertake very gently, very specifically, but be very mindful of how people are feeling. So you need to go into those interviews with that information, because if you see people are struggling, you need to give them that support. If they're the investigator, what support can they have? Well, they can have support from the experts. We've already said about the experts. You need to know when you're out of your depth, and you need to know when to call in help. You can get support and guidance from the governance teams, who would normally be doing those investigations if this is something different that you wouldn't normally be doing, or whoever commissioned the report, they should be supporting you as well. There's also the senior staff in the organisation. No senior member of staff will deny you 5 minutes just to talk through something if you've got an issue you just need to discuss. But then if you're the commissioner of the report, where can you get your support from? So again, the senior staff from the organisation, they will guide you and direct you with where to go and what to look for. But also, if you don't have the skills and the capabilities within your organisation, you can look external. You can look outside. There are external agencies who will help and support you. Other trusts will come in and support you. Reciprocal arrangements, we've done that before. So there are various methods and various people to support the whole way through to whatever level in the investigation you are, either being investigated or actually undertaking the investigation itself.
Yeah, that makes a lot of sense. And investigations can be very emotional, and it's a tricky balance, undertaking an investigation and making sure you're able to look in the areas you need to, but also to support the people who were affected. And it's a really important role, but it's very, very tricky to balance all of the competing demands and pressures and people's emotions around that, because it can be very emotional.
Being an investigator is a privileged role. You have somebody in front of you at their most vulnerable, and actually for them to come out of the interview feeling that they are supported, feeling that they've been listened to, feeling that they understand the situation and what's happened to them, it is actually a skill that you need to develop and you need to grow, because staff should not feel that you are blaming them for anything. It should be a supportive experience. They should be able to go away then and reflect and think, actually, that was good. I've done some good, because that's what you want them to do. It is a very supportive process, or at least it should be.
Question 5 is, what part do human factors play in a COVID-19 investigation?
Okay, well, human factors has been around quite some time, originated from the aircraft industry, where they have a completely different culture to health and social care. Their culture has been for a long time very open, very honest, very supportive, and very encouraging in terms of people being able to identify issues, report them, and have them investigated and learning from them. So within healthcare, we've only recently, and I mean the last sort of 10 years recently, looked at human factors and how that impacts upon what we do and how we move forward. There are loads of models out there you could use, but I would advocate only using a model in human factors if you've been trained to do so, because some of them are a little bit complicated. As an example, the Shell model is probably one of the most simplest. It talks about 5 different things. But if you then relate that back to what we've talked about over the last 4 episodes, those items have been covered, but have been covered in a different way. So there's a different slant on the same question, if you like. So they cover the majority of things, as I say. They look at policies, they look at procedures, they look at how people react to them and how they stick to them, how they use them. They'll look at the environment, both physical, environmental, in terms of what's happening at the time. So it is very much in the here and now. They look at team working and how the team interacts with each other. They look at the communication, they look at the leadership. They look at how people respond, looking at stress levels, looking at, the worries and concerns and the baggage people bring with them to work. They also look at people's personal responses. So that's not just in terms of the staff, but service users as well. So we spoke a while ago about people with dementia, people with mental health problems. That's where that sort of situation would be covered. So everything we've spoken about would be covered in a human factors model. It would just be slightly different slant to it. You'd look at people's knowledge and skills bases, their stress levels, their support they felt they were receiving, their own physical nuances. So if you had staff members who were ill with underlying health conditions, what impact did that have? How were they treated? What did they do? Or if the patient had underlying health conditions, what did that mean for the patient? What did that mean for them? But ultimately, what you would do at the end of it is review the whole thing. You would look at how people interacted with each other. You would look at how communication affected what people did. So as an example, we know the guidance changed on a regular basis. We know, because it was a pandemic, because it was new, because we were learning as we went along, the information we were receiving was changing constantly. So how was that information shared and how do people respond to it? What did they do with that information? Were they able to use it effectively? Were they able to respond to it, or were they not? And those sorts of things would be very much highlighted in the human factors approach to looking at this. But at the end of the day, what you want is an investigation that covers all aspects, all elements, and actually comes along with a set of learning. Now that could be learning from good practice that we can share, or it could be things that didn't go quite so well that we want to prevent happening again. No matter what approach you take, as long as you stick to an approach, you will get the results you need.
Yeah, that makes a lot of sense, and is something that sort of fascinates me a little bit, actually, the human factors, because yeah, you can see that definitely in investigations, how those things played out. And yeah, it's really, really interesting topic, and I wish we had more time to talk about it, to be honest. So Lesley, we have now come to the end of this series. Is there anything else that you would like to add?
I suppose really from me, it's a thank you. Thank you to Fassia Melius for facilitating this. Thank you to yourself for talking to me. And thank you for the people for listening. It's been a pleasure. I really enjoyed it. I suppose if I can give people a message, it's about please, please, please share that good practice, because we need that out there as fast as possible. We need people to know how to respond if it comes back and what happens during flu season. But most of all, everybody, please stay safe out there. Thanks ever so much.
And thank you, Lesley. It's just been so lovely to sit here and take in all this information, and for you to be able to share all of that over this series has been really, really important. And I know that there'll be people out there where this is really, really helps them in undertaking investigations and maybe changing their approach or looking at new things. And I think, really valuable information that's been passed on, and I'm just really grateful that we got to do this. If you want to read the full article, you can find that on the Fassia Melius website. That's fascia-melius.org.uk. I will leave a link in the description so you can go and find that. You can follow Fassia Melius on LinkedIn and Twitter. The links will be in the description. And Lesley has created a contributory factors checklist, which is free and downloadable on the Fassia Melius website. So I suggest that you head over there and download it and use it in your investigations, because I think it'll be really, really helpful at helping you to focus on all the aspects that we've covered in these episodes. And thank you to Fassia Melius for sponsoring this series of podcasts. It's really, really valuable information that has been passed on by Lesley. And so I'm really grateful that Fassia Melius sponsored this and we were able to put this content out. And if you're joining via YouTube, please like and subscribe and you'll be notified of our next episode. And if you're listening on a podcast, then definitely subscribe. And we want to take this opportunity to thank you all for coming over here and taking time out of your day to listen to us. It's been such a great series, and I'm so pleased that we got to do this. So thank you all so much from everyone at the Healthcare Huddle podcast. Take care, and we'll see you next time.